Well, hello and welcome to another episode of Boombostic Health. We're here at the Innovation Summit in Indianapolis. We're actually overlooking the city. We can see Lucas Oil Stadium over here. It's a beautiful day, as it always is in Indianapolis, Indiana. Sunny, usually like in the 70s. It's just perfect. And we're gathered here in Indianapolis to bring together a multidiscipline group of executives across diagnostics, health systems, health plans, pharma, med tech, and it has been the most powerful collaboration that I've seen candidly at any get together of this kind. And it's intentionally designed to be small and to bring the people in that actually are getting things done. So thank you so much for being here. This podcast here is about the connection between diagnostics and value-based care and about the future of delivering healthcare in a more proactive, preventative way and doing it in a manner that actually saves money while driving much better outcomes. And it's not just a bunch of hot air. We've got some very specific examples of what's working and what we're doing. And we will have a portion toward the end that'll be more interactive with our audience to see if there are any questions and there's any input. So I'd love to welcome, though, my two guests here, Gary Albers, who's with the United Healthcare Value-Based Care Group. And you can go as well. And then Steve Serota, who is running the Wisconsin Diagnostics Laboratory, which, as the name would imply, is in Wisconsin and part of the Freighter healthcare system.
We're very creative.
Yeah, that was brilliant. And at least you know what you're talking about. It's not some acronym you can't understand. So, Gary, why don't you just give a little bit more color on what you're up to?
Sure.
And, your background.
Sure. All right. Perfect. Yeah. My name's Gary Albers. Right out of college at Indiana University, where Brad and I went, founded an organization that did outpatient medical imaging. We had about 36 locations nationwide. And really, at the time, we were we were doing them as IDTX, outpatient diagnostic freestanding facilities. And, we were seen kind of as bad guys. We were seen as profiteers. We weren't in the hospital systems. But this is what really led me to start thinking, wait a minute, better service in a more timely fashion with world-renowned radiologists at a lower cost, and I'm a bad guy. How does that make sense? So we went through that, sold that company to a private equity firm right around the Deficit Reduction Act. You guys may recall that. Took a 20% hit in outpatient medical imaging, so highly leveraged with all of the equipment that we were purchasing. Spent a couple of years after that in the sabbatical, kind of getting my MBA and studying, actually founded a company that didn't make any money. And it didn't do any good for my health. But spent 2 years doing that, and then this drive to value just was killing me. So I founded a company called Imperium Health, spent some time with the Center for Medicare and Medicaid Innovation writing the first ACO programs, won an award in DC for innovations in healthcare. So went out there and spoke. Found my way to an organization called LHC Home Health. Always had this feeling that if we were really going to drive value, it was going to be by seeing what social determinants were going on in the home. Everybody showed up at the doctor in their best underwear, and that we needed to get underneath that. So I partnered with a home health company. CEO there looked at me and said, I can't go where you're going on value. We drive a 3% margin business here. We've got to dig in on focus what we can on fee for service. They then sold to Optum. Ironically enough, the new CEO at Optum Healthcare, Patrick Conway, who I helped write the first ACO program. So Patrick and I are helping lead the direction and strategy for value-based care for Optum Health, Optum Insights. So yeah, I'm kind enough to work with Brad and Decision RX on some things, and we'll get into that.
You have been kind enough to do that for me, and I appreciate that. And I also love that you're an actual entrepreneur who's been through some of those ups and downs. Thank you for being here. It's Steve Serota. We'd love to hear a little background so everybody knows where we're coming.
Yeah. So I'm actually a hospital administrator by background. I worked across a number of different health systems in Chicago, ran surgical services for Rush, perioperative services for them as well. And I actually got into the lab space almost 20 years ago now up at Northwestern. They brought me in to build, kind of redefine their lab for them, built them in clinical outreach. And while I was there, they said, hey, look, we don't have specialty pharmacy. Built them a specialty pharmacy and then took over their laboratory services, and then got the opportunity about 9.5 years ago, got about a laboratory divorce that was occurring between LabCorp and Freighter Health. And what had happened is they had created a company called Dynacare, and run for a number of years. And Freighter at one point kind of decided that, you know what? Medicine should be a core competency for healthcare systems. And I think, as everybody in this room knows, that's a fundamental truth. And Freighter decided that the partnership was no longer effective for them, and they, split up. LabCorp took all of the outreach work and freighter with a hospital-based laboratory and a 2-year non-compete. They brought me in to the successor organization, which was Wisconsin Diagnostics. We then proceeded to rebuild core infrastructure, outreach infrastructure with a directed focus on patient-centered care. And the idea that high-value laboratory medicine is a differentiator for patient outcomes and the financial health of hospitals and health systems. We're able to go back out to the market, regained a substantial market presence, and have been growing locally, regionally, and nationally ever since, with this core foundational idea that providing patients access to the right test at the right time for the right reason is how you drive healthcare forward. And, people ask me often, because I am not a laboratorian in my background, how or why did you get in the laboratory space? And I tell people all the time, there is no place where patients interact with healthcare more than through laboratory services. And with great power comes great responsibility. And if you really want to change the course of the healthcare industry, the best place to do that is starting in the lab. And we've continued to do that and proliferate that vision across Wisconsin and beyond. Now we offer tests nationally. And then about 2.5 years ago, we recognized that one of the major problems in the marketplace is there were patients who were getting great access to high-value care if they lived in and around academic healthcare centers that had great laboratory services, but that wasn't everywhere. And those academic healthcare systems also had reservoirs of capacity. So it wasn't that the testing wasn't available, it just couldn't get to the patient. So we said, well, how can we work and fix that? And we started a company called Ottawa, which is a tech-enabled clinical partnership platform that connects academic and affiliated health systems together so they can create an integrated mesh network of care. And they can collaborate on not only improving innovation in the laboratory space, but on serving more patients with high-value subspecialty medical laboratory services. And we've been growing that ever since, and have had the opportunity to partner with HD1 on a number of innovations. And really the reason why we're up here is about having that conversation on how diagnostics can help lead to high-value care and value-based care.
That's awesome. Well, you've gotten much better at describing that. First time you said it, I was like, it took 20 minutes and I was confused. And now I'm like, hey, that makes a ton of sense. So,
Okay.
but in all seriousness, really cool, innovative things that Gary and Steve that you're doing. So we have been living in this fee-for-service world in healthcare for a long time. And everybody knows that means the incentives there to do more and more and more. More tests, more appointments, more, like that mysterious follow-up appointment you have to go back for at the doctor's office. We just check in, that's fine. It's because it rings the cash register. And that, unfortunately, has been a perverse incentive for a while in healthcare. And we're now moving into this era where there are true models to deliver value. Yeah, we talked about this when we were 12 years old, and here we are. It's still,
Great,
kind of the way it is. But Gary, you folks at United and your group at Imperium have implemented some pretty powerful capabilities. But before we get into the real specific stories, can you talk about how big value-based care is for the overall United, patient population, where you're going? Is it getting adopted? What's going on?
It's getting adopted. As I mentioned, it's at a glacial pace. I mean, I thought we'd be way down the line 15 years ago. There's been some things that have happened that have really kind of expedited that. I think the VRDC access that people now have access to around Medicare claims that allows for some de-identified stuff. So it's the whole bolus of Medicare claims. There's kind of been a flattening. Scott and I were talking about around this data. But like a whole, we're about 15 years young in this move to value-based care off of fee-for-service. But Medicare's made it clear that their direction, and they've doubled down on this. I was at the National Association of ACOs, and Dr. Oz was there, and he says, by 2030, our goal is that every government-paid patient in a value-based care program. So we're about 48% of the way there right now. So there's still over half of the population care program. So they're doing some things around the ACO program. There's some new stuff coming out now that will help expedite that. But I think in general, adoption has been slower than expected, but they're very clear that the directive's going to be everyone's there by 2030. So when you think about that, it's 4 years away. That's another 52% of the patient population in value-based care. It's really tough trying to get people to understand how the overall healthcare system's affected by the fee-for-service and those appointments you were talking about that may be potentially unnecessary. We started to go down that path with bundle payments, right? A little bit in with like this, looking at a specific episode of care and saying, is it a hip replacement, a knee replacement? Here you can go home after this. You don't necessarily need to stay in a skilled nursing facility for several days and cost a ton of money. I think the evolution of this is going to kind of some of the stuff that we're doing around the precision medicine. We're looking at it. We looked at it from three very specific use cases when we partnered with Decision RX. One was urinary tract infection, right? We do 8 different antibiotics for urinary tract infection, and people just keep going back. So we said if there was a way for us to circumvent that and maybe do this precision testing on the front end and not have them go back for 7 different times and absorb all that cost. We've got some good studies going on with that.
Just to zoom out for a second, because we had already started talking about this, so not everybody necessarily is grounded in what you're describing. So within Health Cloud Capital, we have a company called Decision RX that is doing medication optimization for value-based care specifically. And United with Imperium and Gary is the largest customer for that. And they were smart enough to see that by connecting in all these different risk vectors in one model that was tech powered and including genomics in this in concert with drug and these other factors, you could actually get to an optimized medication therapy that then when you implement that optimized therapy, it, as it turns out, saves a whole bunch of money. But it all starts with a diagnostic coupled with all this other information.
That's right. Yeah, we're leveraging it with statins as well too, and with psychotropes, right? People just try different ones and they don't get any better, so we'll just try another one.
Right.
And so we got to quit like broad shooting. We got to be more scientific with what we're going after. And I think the Decision RX has really helped us do that. We've got some nice studies. We've been at it a year now. We've shown that we've been able to reduce the overall cost of care from a long-term perspective of these patients by up to 30%.
And we're studying those outcomes.
We are studying.
We'll report that out actually to the group that attended. We'll make sure we get that study out, and Johns Hopkins is publishing with us on that. Switching over to Steve here in terms of what you've just heard with Gary. First of all, you have to share my enthusiasm for the fact that these folks are connecting all the way through with value-based care.
What I heard there, and Rob Rochelle's out there, and I'll tell you, he knows I'm a cockeyed optimist about everything in life. But the fact of the matter is, patients and progress are not mutually exclusive, right? We have been waiting, but the moment is now because we're at a place where this data is available. It is publicly available, and we can start to actually make more directed, clinically informed decisions. And that is meaningful. That data has always been out there, but it hasn't always been information. And there is a real clean line that delineates the two, right? Where the laboratory has been for a very long time, because I'm going to bring this back into diagnostics a little bit, is we are and still are exceptionally good at creating data. But where we need to move into the future is a place that, and there are a number of us who are good at this today, but it's not industry-wide, is to be able to convert that information into actual intelligence and data in a meaningful way. And that's actually why I was so excited to be able to participate in this panel and really talk to you a little bit about some of the things you guys are doing, including Decision RX as a model, because that is how we start to align incentives in a meaningful way that shows that you can do well by doing the right thing. And that when you are taking the right intervention at the right time, you're creating requisite value not only to the balance sheet, but to the outcome of the patient. Because we all know a test that a patient can't afford has no value. So how do we make sure that we're doing the right thing at the right time and documenting it in a way that we can continue to iterate on it to make it better and better for all those patients who serve?
Just really quick to tee this up and spy where you're going. But you made this comment about the trust can't afford the thing that the patient can't afford. Well, the interesting thing is payers don't necessarily always pay in a fee-for-service model for things that really, and one of those areas is pharmacogenetic testing. It's been this crazy paradox where there's all this research and proven effect of doing the right test to align your meds with your genetic profile. And people have been pushing this rope to try to get it paid for more. We just said, forget it. We don't care if you don't pay for it, because the savings we're going to drive side is going to be so much bigger anyway that we'll just share in that and that'll work. And I'd love to hear your comments, Gary, on that, because I think we're the only ones that have actually cracked the code on that I've seen.
Absolutely. So this is where like the move to value really gets traction, is when everybody's pushing the same way. And so when we partnered with DecisionRx, we did Sonic gain share and said, okay, we're going to take this subset. This is part of the wonderful data that we now have available to us, is we can actually mine the data, look at the patient, look at what we've spent on them the past 5 years, how many different times they were hospitalized versus after our intervention with it, right? And after we get a chance to do our testing on them and get them to the appropriate test. And it's unbelievable what we're able to say going forward. So rethinking about it, I think really the thing is, if you want to succeed in value, you have to think about your value proposition and how you can gain share on this. And I think that's one of the things, Brett, you guys were very open to me about when I came to you and said, hey, how about you gain share with us? Let's just take this population follow-up. And for say, if like we're in the same boat. And I think that's what we're pushing from a global perspective, a lot of the healthcare providers to start thinking in that way. Where does the role that they play in the healthcare delivery system, and how can you affect the overall outcome and expenditures for the long term?
Well, this is the fundamental challenge with value-based care. And a lot of times we hear these phrases and acronyms, and it's not really clear what we're talking about. And you kind of have to walk in the shoes and see it on the front lines. But fundamentally, when you shift from fee-for-service to value-based care, the way you get paid is largely about your ability to demonstrate some savings. Well, how are you going to make any savings if you don't change anything up front? And how are you going to change anything up front if you don't have any money to do it? You see what I'm saying? And so then you have the federal government saying, we're going to change everything to value-based care, but you can't get paid anything until you prove that you did it, and you don't have any money already. And we don't want big business and private equity and all these folks to own this space. So it was this really interesting thing we had to crack the code on. So we went out and convinced Carlyle to extend a $100 million line of credit that every time we deploy DecisionRx, as we're doing with you, we pay for the initial deployment, and we get basically a lien, our collateral is the receivable. And so we're actually, taking real risk. But, there's that aspect of this world in value-based care, which is how do you just finance it? There's also like the workflow part of it, which is totally different than the traditional. And so I think it'd be interesting for us to unpack. So, we want people that come to this and are part of it and that hear the podcast to come away with a couple of things that are either new ideas or new things that they've learned that they didn't know otherwise. And I think this is a great opportunity for that. So maybe I could have just the two of you guys talk about from the front end of the primary care works there. Because ultimately what we need is that the primary care docs to actually adopt these things, right? To the workflow on the diagnostic side. So maybe start with that and then get into how does this tie into diagnostics?
First off, we're not making very many more primary care doctors, right?
Mm-hmm.
So I've always thought about looking at this as expansion of access to primary care. This care perspective has to be done with the expansion of access to the PCP. If we could do things that provide them with the ability to quarterback this in a much more efficient way, as opposed to sit back and wait till they come back to them. And so that was this precision medicine that we were using. And that's really the gaps in care closure stuff. I was talking with one of the guests here earlier about gaps in care closure. So being able to do that at a real-time perspective and do that in a manner with which is proactive. It's fascinating with all the information that we have now and everything that we're doing and all this potential for AI that's out there to see the healthcare system become a flatter place. It's going to be that everyone's going to have access to this data information, and how we use it and how we gladly decides the best path for it. It's going to be exciting. It's going to be really great to see.
Yeah. And I mean, I think where the rubber meets the road on this, right, is about information and about how you can utilize some of that in a meaningful way. One of the big challenges that we see today, right, is there's such a gap in who has information, when they have that information, and how they can use that information to actively drive that value. So one of the things that we actively work on is there are simple workflow changes, right, that you can start to empower. Right now, a lot of us will go to a doctor. They'll order tests, or even if it's an annual visit, they'll order tests, and you won't get those test results till after you've seen your doctor, and then you have a follow-up. Well, if those test results came before you saw your doctor, Your doctor then could talk to you about those results. So as simple of things as understanding the where, the when, and the how, and how do we drive that to a meaningful conversation? Because at the end of the day, AI can inform, but people have to decide. And healthcare is a deeply personal and human business. So we have to make sure that we're in primary care providers with that information to keep that human connection meaningful, but to do so in a way that drives value. And, as we dig into it a lot, one of the places that we consistently look for this is how can we put the right diagnostic tools at the right point in the care continuum to make sure that every choice that follows is based on data, not just based on, hunches or feel good.
Well, I think you're exactly right. And I think looking at it, I'll use the ACO space, for example, and value-based care. That's what I know the best and the most. And we always got Part D information, claims off the patient, but there was no incentive for us to do anything about it. We didn't get cost savings on Part D. So that's when Brad came along. We started talking about reusing lab data in a different way. I'm not just looking for compliance is a big thing always, right? But not just looking at it, or they using, generic stuff. But how do we leverage pharmacy to create savings from an overall outcomes perspective? And I think that's really what we've succeeded at, is rethinking about the delivery system, rethinking about what the role is.
So much of the friction and how slow it's moving is this problem of the historical precedent that's there. And it is so hard to rewire the way people think in general. And the example here, as we're talking about this connection between diagnostics and technology and really a concierge level of pharmacy that's for the masses, though, right? You don't have to pay extra, is when you raise this to a health executive or a health plan, you can explain to them, you can get on the whiteboard, you can draw a picture, you can write the numbers, and then they go, well, so does this make sure we use the cheapest medications? And you just are like, okay, let's start from square one again. It actually doesn't matter that much whether the pill is cheaper or more expensive. That is a tiny rounding error compared to the expense of what you're referring to, of somebody failing to benefit from medications because they're conflicting each other out, or they can't metabolize them. Or, in that case, you're just creating expensive urine, and the problem that they have with their health is persistent. But you were able to understand that. Which I give you a lot of credit for it. But why is it so damn hard to get people to understand that it's way more expensive to have a bad health outcome because the medical costs are so huge? And then 10 minutes later, they come back, it's like Dory on Nemo.
Right.
It's like they forgot everything you just said. They're like, well, how do we get the cheapest pill? I'm like, who cares? But nothing understands. How do you get it? Why can't they?
Right. It's an incentive alignment misstep. There was no incentive to do that prior to value-based care. And the move to value was just like, okay, whatever. When you start moving this to value, you just start thinking, you should be thinking about things from a different perspective and a little different angle on it. So there's incentives, and they're not close to being aligned. Thinking about things just from a different aspect of how do I utilize this particular tool with overall savings for the patients, and it's the right thing. And so getting to health plans to restart thinking about how they're using this and what guidelines they're setting. And prior auth's one of the things now that they're starting to do away with, right? Everyone's feeling a little pinched, but always just felt pinched by that, but starting to contemplate those things. So I think, again, it's a glacial pace, but we're moving. So it takes innovation, though. It takes innovators to be thinking about, and this is probably right to how you try to skin the healthcare thing. This is, I saw stats this last week at HIMSS that 240% is what the healthcare cost has gone up over the last 10 years. We have fewer PCPs. That's the other challenge, right? We've had these large healthcare organizations that have controlled a large portion of everything.
Well, and I think you touched on probably the most important piece of the whole thing, right? Which is about directed incentive alignment. And one of the big challenges, as you alluded to, is this is great from an entrepreneurial perspective, but right now we're living in a mixed model. And a mixed model, and anybody who's taken classic psychology, you want to screw things up, change up your reinforcement pattern, right? Because you're telling some people to do something one way for some people and do it another way for other people. And that just is incredibly difficult as a clinician who's trying to focus on an individual patient. Now you're adding a layer of complexity associated with how you're getting reimbursed. I mean,
Absolutely correct.
if there's one thing we know in the lab, standardization, 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 right? We don't like any missed attempts. We don't like things that look like they could be missed attempts in the future. And we've created a healthcare incentive base that is driving for these mistakes on purpose. And the other piece, which I'm actually really interested in your opinion on this, we talked, the other variable that we don't talk about is that patients have to be involved in their care.
That's right.
And what is really unique when you start to think about value-based care, and especially investing in diagnostic tools, when you have a patient population that moves,
Right.
health planners, how do you have that conversation with a health plan and say, hey, look, we want you to pay up front for a comprehensive pharmacogenomic panel, knowing that patient may only be with you for a year or 2 years and never get the value up.
And you hit exactly one of the big barriers to that is that it is a fluid environment. Fair. To start looking at that, right? It's the fluidity is a huge thing, but I think in value, we can explain to the doctors, we can explain to the insurance companies, we explain to everyone what their role may be, the lab, what your role may be in its overall value, but no one's touching the patient to explain to them why we're making this move to value of what we're doing. And so the patients continue to navigate the system the way they want to. They'll go to the ER because they need their prescriptions filled and will get hit. It's unbelievable how patients in Medicare has been set up that way to date. They're starting to provide some guardrails for that through the new programs where we can do some more effective contracting with groups and start more steerage of our patients. I think they're really, they don't want to have that steerage aspect, but they realize there has to be some element of that in order for it to be effective. So, it's this whole patient engagement thing, and it was one of the buzzwords early in the move to value. Like, we just missed it. We just skipped right past it. We went on to social determinants of health and other things and never really told the patient why the doctor's doing what he's doing and why I'm calling you to come in for your annual examination. And oh, by the way, it's on you. I'm more curious about how you're doing mentally, how your fall prevention, smoking cessation, those things that don't require a stethoscope. And the patient leaves wondering, what was that? That was my annual wellness visit, and it's more of an annual well-being visit as a whole, So it's interesting. There's incentives now. Patients can decide, that's my doctor. That's what I want to do. They're kind of helping some of that, but we churn about 20% of our patients every year, even in Medicare, right? So it's tough. You're exactly right. I think the disconnect, we got so focused on everything that we had to do to survive in the value and the move from fee for service, and we just kind of let the patients twist in the wind on that one. They understand what their role is and that I need to call my primary care physician if I'm, for various things and not just run to the ER.
Well, and I'll take it one step further. I think part of the challenge that we run into right now is, we talk about this care crisis. I think it's a crisis of trust. And we were talking about this before. You go back to the late 90s, early 2000s, the second most trusted brand in the country was Blue Cross. And now we talk about insurance companies like they're, the evil empire. Exactly. And that erosion in trust has kind of sowed these real challenges with this. And Brad, I know this is your show, but I'm going to ask you a question because I think this is really kind of an interesting interplay here. How do we take this data that we're getting and move it in a way that it is more consumable so we can engender that trust, not only with the provider, but the patient?
So the question around how do you move the data, I think your comment earlier about when do you generate the data along the journey so that you're more proactive and fee for service. Being more proactive and gathering data is more aligned with value-based care because it results in some type of action that actually moves the needle on the economics that's measured. And so I think the advent of all of this new big scale, relatively new, like you talk about the last 15 years has been value-based care. It's really been the last 15 years that cloud native and now AI native capabilities have started to exist, which I think is sort of just in time to be able to start making a dent on how you can deliver healthcare better, the actual need. So to answer a question that relates to what you're saying, I think we need to be able to automatically and continuously measure and report out on how these data or insights or interventions are making a difference. And I think that's what we've done recently with DecisionRx on more of the, when you optimize medications, this is the outcome and this is how much you save. But think about connecting that all the way to the diagnostic. When we do the diagnostic, and not just for a thing, because I know, Robert, you talked about, I think CKD was an example that's been studied, but think about that in a broader sense, like the central nervous system of healthcare is all this diagnostic information, yet it's just viewed as, what did it cost me to run that test? But what if we can actually start doing that health economics research, if you will, on a continuous basis, which I think, because you have to win hearts and minds. And I think that's what I've seen with the value-based care thing is we're starting to win hearts and minds with these people who are delivering care. One, because they're getting more money, but two, because they're saying this data that we're leveraging is delivering on this value. And so it's, imagine having a conversation now about the pharmacogenetic test in concert with all these other risk analytics we're doing, and that we can say, hey, look, over the last 12 months, we've delivered the savings, and United Healthcare is completely on board with that and actually has signed off on that at an actuarial level. So, because the other question is like attribution,
Yes.
you know? So you think about a program for value-based care, and the easy thing for the provider to say, or the health plan to say down the road is, okay, cool, we saved 30%, but we did all these other programs. How do we know that what you did saved 30%? So like, that's a whole other data issue. So it's like, on the front end, there's the diagnostic and the assessment and the things you can do to be more predictive. But then on an ongoing basis, there's this measurement that has, I think, been completely lacking, right?
But it's difficult to figure out the weight that each intervention actually causes there's some of that. So that's where really like, okay, was it the preventative services that we did, closing the gaps in care that drove that? But it's like you can start to pinpoint that because the data is getting better, right? So typically 6 months to get any sort of real data on anything. And now it's coming in a much more timely fashion. So it allows us to really optimize what we're thinking, optimize the strategies that we're deploying, but also really drill down on what's making the impact.
Yeah, no, I agree with you 100%. I think we're seeing it in diagnostics because, especially if you take academic diagnostics, we took this, let's sequence everybody and let's look for the largest number of genes we can find. It doesn't matter if they mean anything today or that we have any understanding of what it is. Let's just get it all. And when we do that, we devalue the subcomponents of what actually has clinical relevance today. So if we can, as a diagnostic community, get really, really clear around this is what has clear, present clinical relevance today. This is, maybe next step that is research and informs research and otherwise, which has requisite value, don't get me wrong, but maybe it's not directly tied to the clinical outcome of a given patient. So if we can get surgical and, use a scalpel instead of a shotgun, we can be much more effective at saying, hey, look, take this intervention. Let's take this very acute specific tool. Let's use it because it drives value today. And that, I think, is one of the ways that we start to really champion that trust back up, because we do what we say and we say what we do.
I think you're flipping those things from nice to have, right? Like it was nice to know that, to actually application that shows.
Yes.
And it equates to value. Yes. And you can use it. Before it was, this testing's been around for a long time, right? Show us some things, but then how you equate that to actual interactions that drive healthcare savings in dollars is the important thing. And I think everyone in their role and value is starting to drive.
So let's shift gears a little bit here and talk a bit about the future in a more ambitious, abundant way. So I keep referencing the fact that I've got many biometrics. There's this advent of diagnostics getting linked, actual lab diagnostics getting linked to your biometrics. And I just wonder how soon it will be that, similar to if you're a teenager in particular, the car insurance will give you a discount if you're willing to have the app on your phone that monitors how terrible or good your driving is. How soon will the health payer world to, hey, if you're willing to monitor all these things and let us connect to it and see it, we'll give you a much less expensive health plan.
Yeah, so that's very interesting, because I was talking about our value-based contracting people around this, about how we rethink. I mean, Now they'll provide you a discount if you go to your annual wellness visit, right? But the real application with all the other stuff, I mean, it's definitely something that they have to be thinking about, and have challenged our contracting people to think about what is value? What creates that? If you're providing more information, that's valuable, right? To the healthcare companies to help them understand what you're doing. They're trying to incentivize the right behavior and give you a little bit of a discount. Yeah. We all do that. So I think, how does it go to the next step from there? How do we just not say, come in for your annual wellness visit and we'll give you a little bit off? It's what really drives that patient to do the right things and to provide that information for the healthcare dollar? And it's something that, I mean, I always think about this, and this is maybe not the right way to think about it, but if I was a self-funded insurance company, what information would I be paid for? I'm not a health plan, but I'm a self-funded insurance company. What do I want my patient to do? How do I want to go about it? Because talk about unsustainability is that 12, 13% increase in healthcare costs every year that are being hit to these companies. So I can't wait to take the information we've been learning with Medicare and this for years and start applying that to move towards 2030. We'll have self-funded organizations coming.
I agree with you completely. And I think there's an interesting fountain innovation that does come from employer-based points, right?
Yeah.
Because that is where you see true acuity, right?
That's right.
This is, if I've got one person who gets sick, it changes my entire PMPM cost structure.
Yeah.
Right. But what gets very interesting here, and this is where the intersection of health and ethics always comes into play, right? Yeah. We talked about the patient responsibility, but it gets a little sticky and ugly when we start to say that patients are responsible for their comprehensive state of wellness, right? We kind of want to say that, but we don't always want to say that. And how we can start to get to a baseline through informatics is a really interesting question, because you and I kind of talked about it a little actually before this. Even when we're doing some of these contracting, we're not necessarily coming at it from a holistic understanding, because we don't have all of this data on the front end. So when we talk about how are we driving value, we may have some of the financial data, but we don't necessarily have a full picture on health, the current health state versus future health state. So how do we get more encompassing when we think about how we are contracting at the very beginning? How are we building the value-based care? And how are we reaching out to those patients to create that synergistic alignment that drives to an overall better state of health for our communities? And that's, I think, where the rubber starts to meet the road.
So it's such a fine line with patient satisfaction, right? I mean,
yes.
That's one of the areas that we monitor. It's how was your experience, right? But there's all this big brother, I don't want you on everything that's going on. And, but so there's that fine line that we have to walk. And we get a lot of it in the Medicare space about utilizing that data. The patients feel like it's big brother, that it's big government getting in and looking at all that. The reality of it is it's because we can use information. So it's just a fine line, and it's a trust. Back to that healthcare trust that you mentioned earlier. I think people have just become disenfranchised with healthcare in general in the United States. It's expensive. It's not timely, right? So how do we address those things and kind of start to move it towards the value?
Well, I predict that at some point, probably one of the hyperscale companies like Apple, for example, will launch the first ever health plan that is mandatory for you to have this biometric monitoring. And in exchange, you will have a much tighter, less expensive, more integrated approach to how your healthcare gets delivered. I think probably Amazon has somebody thinking about that too. So with that, I've said this already yesterday, I can assure you that by this summit next year, we will have an analog study for diagnostics to what we're doing with prescribing optimization, which, as I mentioned, we'll circulate that when it comes out here in Q3 to this group. And it does tie to diagnostics, this Johns Hopkins study, but it's all the way through to when you drive the new medication therapy regimen, how do you save money? And I think for the entire diagnostics industry and for value-based care, having an actual study that's real, that's not just this anecdotal, hey, 80% of decisions are based on lab. Okay, cool. Well, what does that mean? How does that actually deliver on this end result? So we're gonna crack that code. So with that said, we have, I know, run a bit over on this, but we started a little late. So if there are any questions in the audience, we would love to have a couple of Q&A items here before we shift to the next podcast. Looks like Valerie has a question.
Great discussion. Is this on?
Yeah.
Great discussion. I had a question in terms of So 5% of the population makes up 50% of the healthcare cost. 5%. What value-based programs are you thinking about, have in the works to focus on chronic disease, cardiac, Alzheimer's, diabetes? Because those are the home run.
That's awesome. So just announced recently is the new LEAD program for account organizations. It's called REACH before that. Now it's LEAD. Within the LEAD program, we have the ability to break our chronic condition patients out. So the highest cost patients, and we can put them aside and manage it. We actually get an incentive from the government for doing so. So they'll pay us up front for some of that cost that we're going to incur to do the preventative services on it. That was one of the arguments always, and Brad mentioned it earlier. It's like, okay, so I want to raise the value, but I don't have the investment. I don't have the time. I don't have any money to invest in this. How do I do it? And so we've been beating on that with the government for a long time. And that was the first advanced payment initiative that we did, where they would pay us up front to help do some of this stuff. But now they've taken it a step further. They've lowered the limits that it takes to get in. It used to be 5,000 patients to be at 18. It's now you can be as little as 800. And you can do so in a chronic condition space, and they'll pay you up to $26 per member per month. Because these patients are costing us $86,000 and $100,000 a year. You know, average Medicare spend on a patient's about $13,000, about $1,200 and change. So when you think about that, it's 8-to-1 or 9-to-1 deployment. And so now then we're starting to, and they've lengthened the terms of the program. It used to be that it was a 3-year program. It's now 10. So now we have 10 years with a stable benchmark on that patient, looking back historically, that we can start to judge it off of. Investment in a chronic condition, they're starting to value that. And I think that will have a waterfall effect into the payers as well. So that's a great question. That's one of the biggest barriers to entry on this thing. We know that 5% costs us the most, but how do we fund programs to get after it?
Yeah, and I also think we're seeing some innovative entries into that marketplace. I think it's starting to become omnipresent that management of these chronic diseases is incredibly difficult if you're not getting the patient involved and getting them actively tested. We use diabetes, right? You should know your A1C levels. These are things that should be fundamental, but we have not seen that incredibly strong relationship classically between the payer and the lab to be able to say, hey, look, we know the patients that aren't getting their testing.
Right.
Help us get those patients. Health system, go help us get those patients. And there's some great companies out there. One of them is a company called Grapefruit Health that is employing nursing students to do direct outreach to patients around care gap closure. And the idea here is they get, those nursing students get clinical access or clinical experience and things like that. It's a lower cost than having a nurse or a PA make those calls. And at the same time, those patients are getting that outreach because we know when that outreach occurs, the patient's more likely to go in and actually get the certs. So how do we get closer to that 5%, wrap our arms around them and go, we know what you need to be able to manage that disease better. Let us help you help yourself.
Yeah, absolutely. That's an interesting one. I battled with this early on in the COVID years with the outreach, the chronic condition management that came out. They did Medicare put a whole bunch of new programs out around chronic conditions and reaching out to the patients and telephonically engaging them, and they'd reimburse you for that. And I really struggled with that, if it was going to be effective or not, right? Just by doing that. But I think we were just not ready for that at the time. Now we're dealing with this whole dearth of healthcare expenditures that are coming back after COVID. And this is all the health plans are in this problem right now. All MA plans are upside down. Not only have they tightened the coding, they capped the coding on them, but now are taking these expenditures that weren't there and they benefited from for a lot of years during COVID. Now they're back and they're more costly and they're more expensive. So I think reevaluating that chronic condition management program and engaging the patients maybe differently, not just telephonically, because it was to the point that you could call a patient and be rewarded for just looking at their chart and not ever getting in contact with the patient. COVID gave us the receptivity by the patients to now be willing to take that phone call. It didn't have great adoption at first. And so Medicare, and I'm speaking from a Medicare perspective, they went and rewrote that. We'll see some real movement in it.
Well, that's super helpful. Thanks for the great question, Valerie. Is there one final, any other questions? Go ahead.
Thank you. A number of people this week have talked about, Robert Michelle talked about this, you talked about this the other day, and of course today, about how precision medicine can save cost overall. I know you've been working with prescribers. Is there a push from the payer level to provide this data so they can figure out? So you talk about with Medicare, it makes more sense because you don't have the churn of patients. And so that it's an upfront cost, but that should pay out over time. Are you seeing this push from the payer level or interest in this?
So what we are seeing at the payer level with this optimized prescribing is a very strong willingness to share all of the claims data based on the patient. And claims in the prescribing space are pretty darn specific and accurate. In diagnostics, it's harder because the claim just says a test got run. It doesn't say what the result was, right? So to connect that dot, it isn't always in the possession of the payer to get there. So that's where we're really trying to live in this pay-vider world for that, where we do have access to more of the specific diagnostic insight. But I'm definitely seeing an appetite on the part of the payers to participate with the data if they can see a very clear economic reason to do it.
Yeah, I think certainly there's broadening receptivity to it. Before it was a matter of running the PBMs and getting them on your formulary, and that was really where it stopped. And so now, thinking about it differently, there is some receptivity that I'm seeing the payers start to embrace this. And I think once we prove it and start showing it to them, it's going to be undeniable. So excited to see that play out.
And I think the last piece on this kind of ties back to this whole idea that we classically in the diagnostic space had taken a shotgun approach to a certain degree. And as we've gotten better and our technology and our informatics has evolved, we are starting to become much more precise in creating targeted panels that actually do what we say they're going to do and generate comprehensively clinically relevant data. And when you can present, at least in my experience, to the payer, a very directed correlative relationship between we ran this test, this was the outcome of this test, and this was the action taken associated with it, it's a home run. The challenge for us is we haven't done that. It's not a muscle that we've strengthened over the years, but now because of access to data and informatics and the sort of partnerships that we're building, we're starting to be able to do that in real time. And I think it's being received fairly well.
Well, Gary, Steve, this has been an awesome conversation. Really appreciate you being here. That wraps another episode of Boombostic Health. We will see you next time.